Good afternoon, everybody. On behalf of Iowa Re, I'd like to say welcome to Indianapolis. Thank you for taking time out of your busy schedules and joining us. We have a huge commitment into the medical stop-loss marketplace, and you guys are the people that make it go for us. We appreciate the business that you place with Iowa Re. We appreciate the trading relationships that we share with you. We have two fantastic presenters today that are going to bring some real quality to you, and I hope feel free to interact with them, ask any questions, anything that's on your mind. And as we move through the day, if anything crosses your mind and you'd like to speak to someone at Iowa Re about anything, an issue, an opportunity, or what have you, please grab any one of us and let's spend a few minutes together. Without further ado, I'll turn it over to Connie McClure.
Good afternoon, everyone. Thanks for coming. And I'd like to introduce our first speaker. It's Dr. Stacy Borens, and many of you probably know Stacy. She is the founder and chief medical officer at Advanced Medical Strategies. And AMS provides a very broad range of services that include medical director outsourcing, independent med reviews, underwriting opinions and lasers, provider bill negotiations, bill audits, Medicare repricing, plan doc assessments. As you can see, they provide many services. Also includes reinsurance and MGU reviews, TPA reviews. But what AMS is very well known for is they've streamlined the way carriers, reinsurers, risk takers, MGUs, TPAs, and brokers predict and manage costs associated with your high-dollar claims. Through this database, it's an online database, which is called PredictDX. The subscription-based service details costs, risks, accepted treatments, and other information related to more than 160 of the catastrophic illnesses that I'm sure we've all seen at one time or another. And what it does is it enables us, the users, to predict their liability on these potentially large claims. And speaking from experience, Iowa Re uses the database, and it's an incredible database. It has definitely streamlined our ability to predict costs. Dr. Borens is also the architect of another database, AMS Predict RX, and they're listed up here. This subscription-based service is designed for end users to quickly obtain detailed information on over 350 high-cost drugs, including approved indications for the drug, common off-label usages, pediatric and adult dosing, and specific coding for the drugs, and physician-researched information related to the drugs. And as we all know, our drug spend is climbing on a daily basis. So without further ado, I'd like to introduce Dr. Stacy Borens.
Thank you. So thank you so much for having me. I'm really excited to be here. I always asked me to speak in the past, and I've always had such a good time doing that. So today, we're going to talk about drugs. That's kind of what I'm here to talk to you about. I get very excited about drugs. We see them all the time. They are probably the biggest cost drivers right now for healthcare claims. So I'm going to kind of break the talk into a couple different parts. So the first part we're going to do with some slides. I'm going to give some information, and we're going to talk about drug spend and kind of where things are going. And then we're going to move into more of the good part. I'm actually going to take you through a bunch of different new drugs that were FDA approved basically over the past 6 months. I'm going to go through what they're used for, how they're dosed, and then most importantly, what they should cost you. And then if I have time, I have a couple of hemophilia claims, because that's all about the drugs, that I might show you at the end. It all depends on when Connie gives me the hook to get off the stage. So if you're interactive, she won't pull me so fast, so I would appreciate if you ask questions during it. I'm happy to talk. I tend to move around a lot. I'm sorry, it's just my nature. So I'll probably be wandering through you guys a lot as we go through them. So the first thing that, like I said, I'm going to do is we're actually going to go through some slides, and I'm going to give you some background information. And let's do the show. I know it's after lunch. If you fall asleep, I will pick on you. So please don't do that. And I'm sorry, I got some notes under there, so I'm just going to steal them from you. I left them there. Okay. So, specialty drugs. There's a lot of confusion about what specialty drugs are, and I can tell you, you're late, but I'm waiting for you. What are you doing? So there's a lot of sort of confusion about what constitutes a specialty drug. And if you talk to 10 different people in this room, I'm sure you would actually get 10 different definitions of what we think a specialty drug is. Well, you're in luck, because in February of this year, the National Association of Specialty Pharmacy actually put out a definition of what constitutes a specialty drug, and I kind of excerpted it here for you. And so the first thing is that they're more complex than most prescription medications. Well, what does that mean? What defines complexity? Well, they put a lot of thought into what they decided complexity meant, and here's what they came up with. The complexity could be due to the drug itself, the way it's given, the management of the side effect profile, the management of the disease it's affecting, or the condition it's used to treat, special access conditions. You can only get some of these drugs through either certain pharmacies or certain types of restricted programs because of the nature of the drug, payer authorization, benefit requirements, patient financial hardship, or any combination of these factors. So that's pretty much all drugs, as far as I can tell, unless it's Tylenol, Advil, or Aleve. Pretty much a lot of these things fall into the specialty drug combination. The most important thing to keep in mind is that a specialty drug does not have to be intravenous. It can be an oral pill. And in fact, most of these drugs are oral that are considered specialty medications. And it's because they're used to treat patients with these very serious and life-threatening conditions. And that includes pretty much all of the ones that you would expect. You're talking about cancers. Hepatitis C was the big one last year. I'm sure you all are very familiar with all of the hepatitis C drugs that came out. You're in luck. There was another one that came out 2 months ago. Yay for you. AIDS, tuberculosis would be considered that, multiple sclerosis, cystic fibrosis, pretty much any transplant. So it kind of encompasses, obviously, a wide range of conditions. Again, as I mentioned, they could be taken orally. There are some that are injected or infused. They can have special administration requirements, but a lot of these are actually given in the patient's home. And sort of the classic example of that would be really any of the drugs for hemophilia A. Any of the factor replacement, most of those patients are taking them in the home. They're either giving them to themselves or somebody at home is giving it to them. But as you'll see, their costs and all of the sort of complex problems that go along with them make them really a specialty drug. They can be obviously given in a doctor's office, an infusion center. Those are, you're going to think of some of your chemotherapeutics, et cetera. But most importantly, they're not routinely dispensed at your typical retail pharmacy. And that is for a variety of reasons. But most importantly, that the retail pharmacies are just not set up to really handle the types of questions, the complications that you can actually see for these drugs, and they're really not set up for patient care. So most people are really not driving down to their local CVS to get these types of specialty drugs. So that's really what they are. Again, feel free to stop me, ask questions. I do tend to talk quickly. I'm trying to get a lot of information in, but please, if you have a question, just catch my eye and I'll be happy to do that. If you don't have questions, I will make you have one, so please ask something during the talk. So let's talk about cost trends. Right to the end, spoiler alert, they're going up, just so you know. So in 1990, we had 10 specialty drugs. That's not that long ago. That's only 26 years ago. As of 2015, we had 300 specialty drugs. This year alone, 25 new drugs are expected to receive FDA approval, and that is for a completely new drug. That does not include drugs that are already FDA approved for something else and are going to get FDA approved for new indications. And in fact, I forget when Connie asked me to do this talk. It was, maybe several months ago. And so over time, I've been putting together the different drugs that I wanted to talk to you guys about. And I basically came up with a list of 15, and I thought there really is no way that we can get 15 in an hour. So I did cut it down to 5. And then I put all the slides together, and I thought, this is great. This is going to be a great current presentation. And then on Monday, the FDA screwed me, and they FDA approved a chemotherapeutic that's already on the market called Lenvima for thyroid cancer. Well, they went ahead and approved that for another indication. And I was like, all right, that's fine. I won't put it in the slides, but I'll talk about it and I'll tell you all about Lenvima and what it's now FDA approved for. And then the FDA screwed me again yesterday, and they went and they FDA approved Opdivo for another indication. In addition to lung cancer, they approved it for Hodgkin's lymphoma. So they're not in my slides, but we're going to talk about them because they are the most recent thing. And this happens pretty much on a daily basis. You may not be aware of it, but the FDA approves these things all the time. I will tell you, they typically approve them on a Friday afternoon at 5 o'clock just to make my life miserable, but that is what they do, and they sort of release week over week. So that 25 does not include these drugs that are on the market that are going to get new indications. And again, more good news, under development are about 700 new drugs. Yes?
I was reading recently that the FDA, within the last, I think, 2 to 3 years, has revved up their staffing as far as for the drugs that they're trying to fast-track through. It was interesting reading that, and have you heard that or seen that? Because in reading that, seeing how the drugs are just gradually
Sure.
rise, it makes sense that if they have more staff and are improving more of these drugs,
Right.
more quickly, obviously, they're going to be thrown into the marketplace and they're going to be used.
Absolutely.
We are going to see that.
Sure.
Is that something that you've seen also?
I would say I haven't seen the part about the staffing, but I can definitely tell you that they have ramped up their accelerated programs. And it's really beyond kind of the scope. The FDA has 4 different routes by which they approve drugs, and there are things that get fast-tracked and things called breakthrough therapy and orphan drug designation, which you're probably familiar with, and accelerated approval, and all of those kind of follow different things. And the vast majority of these drugs that are getting new FDA approvals are running through these programs where they're running through a fast track. And what they say on the back end, it's kind of like, if you remember back in the day, Avastin at one point, which, nobody really cares about Avastin anymore because we don't even think it's that expensive. It's just not as expensive as it used to be. So back in the day, Avastin actually had FDA approval for breast cancer, for metastatic breast cancer. But they pulled that about 2 years after they gave it FDA approval. And why was that? Well, all of the confirmatory studies that went along with the accelerated approval showed Avastin really made no difference in terms of disease-free survival and overall survival and kind of a lot of other parameters that the FDA required the manufacturer, who I actually can't remember who that is, to look at. It didn't meet those endpoints. And so what happened is Avastin lost its FDA approval. And so this is what we're seeing now, is that whether it's, I'm sure they ramped up the staffing to be able to meet some of these accelerated guidelines that they wanted to make. And this is what we're seeing, is these drugs are getting fast-tracked, but the studies aren't all in. We don't have long-term data. When I give a lot of these talks about different diseases and different types of things. And like I said, last year was all about hepatitis. Everybody was all about hepatitis. This year, it's either hemophilia, because there's 2 new drugs for hemophilia A and 1 new drug for hemophilia B, or compounded medications. Everybody wants to talk about compounded medications because they're sort of going up. And those don't even follow the FDA approval process. They get used outside of any FDA approval process. So we definitely are seeing the ramp up in terms of getting these drugs to market. But the question is, are they going to last? I don't know, and I guess most of you in this room probably don't care about, are they going to last 2 years from now? But they're going to last this year, and they're going to last in your policy years, and that's why we kind of have to talk about them, because they're all very expensive. You had a question?
Yes. How are those 700 specialty drugs under development?
Uh-huh.
How many of those do you anticipate would actually get approval and to market?
This year or in general?
In general.
That's a good question. I would say historically, when you're looking at that, it's anywhere from a quarter to a third end up on the market. Now, not all of these are going to be, drugs that are very expensive or hard to use, or for, conditions that, traditionally in a catastrophic environment you're going to care about. But they'll still be considered specialty drugs. And it might be because they're difficult for the patient to take, as an example. Maybe they have some sort of strange dosing schedule that makes it fall into a specialty thing, but it could be a very low-dollar drug. So I would say of that quarter to a third that come to market, the percent you probably need to worry about is about 10% of that. So it's still not an insignificant amount. And actually, we're going to. I'll skip this. The spend is ridiculous. It was $87 billion 4 years ago. It's expected to be $400 billion 4 years from now. It's obviously crazy, but it's actually going to be the next slide. I'm going to do that and come back. This is what we're sort of looking at. So the number of new drug FDA approvals in an 8-year span, from 2006 to 2014, was 28. That was over 8 years. Not a lot, right? Not too terrible. 2015, there were 45 new drugs. So that was just last year. There were 45 new drugs, 16 of what we call first in class, meaning no other drug therapy like them actually exists. There's something new about them. They might be a certain receptor that they bind to. And not to digress, but I will. The way that we're treating diseases these days is much different than the way we used to treat diseases sort of back in the day. What we used to do, cancer is an example. What we used to do for cancer back in the day is people got cancer and we took a bunch of chemotherapeutics and we gave them a ton of drugs and we hoped that this worked. And it was sort of the shotgun blast, and that's what we did. And, obviously people had terrible side effects, but a lot of times they worked. And if you were lucky to survive the treatment, you hopefully survived, for many years afterwards. We don't treat cancer like that anymore. Now what we do is everybody's looking for the next genetic mutation, right? We're looking for different receptors. We're looking for anything that is sort of different in the DNA coding. We're looking for targeted therapies. And so what you have is that, and some of you may have heard this story before. I have a colleague that is in our industry that used to work for an MGU. She's in her mid-40s, healthy lady, never smoked, never did anything bad in her life, and she got gallbladder cancer. Gallbladder cancer is a terrible thing to get for anybody, but particularly for somebody who really does not fit the profile. She's not male, she's not elderly, she's not a smoker, she's not a drinker, and she ends up with gallbladder cancer. And unfortunately, with gallbladder cancer, most of the time, we don't find it early. We find it when it's already out of the gallbladder and typically into the liver. And those people tend to have a terrible prognosis. And there are certain chemotherapeutics that we traditionally have used to treat gallbladder cancer. But she went to Sloan Kettering up in New York. And so what her surgical oncologist said is, here's what we want to do. You're really young and we should be really aggressive. And I wholeheartedly agree with that. I think that's what they should do. The woman is in her mid-40s and she should really do whatever she's got to do, taking costs aside. And they said, here's what we're going to do. We're going to take biopsies of your tumor, and we're going to send them out to a lab. And we're going to check for all of these different mutations and see what comes up. And there was something like on the order of 50 mutations. And so when they got her profile back, about 30%, which is not a terribly high number, I understand, but 30% of the tumor cells in her gallbladder cancer were HER2/neu positive. And if any of you know anything about breast cancer, you know that that's a typical mutation that you see in breast cancer, either hormone positive or HER2/neu positive or a combination of all three. We don't typically think of gallbladder cancer as being HER2/neu positive, but she was, and 30% of her cells, which now looks to be a whole lot higher because now we can say, well, 30% of those cells are going to respond to something like a Herceptin or a Perjeta. And so that's what she started to get. So we're not going to be treating cancer anymore by you have it in the colon or you have it in the lung or you have it in the prostate. We're going to now look at it and go, okay, location matters, but what matters more is what is it made up of and how are we going to target that? And that's where all of the drug development is. Everybody is looking to do the next targeted therapy. And a lot of the therapies I'm going to talk to you about, which now we're clearly not going to get through, are going to be looking at these targeted types of things. It's not the shotgun approach. And so people really need to have these specific mutations. It's not enough to have non-small cell lung cancer that hasn't responded to a certain thing. You have to have an ALK-phos or a ALK-positive mutation, or you have to have really programmed death receptors. Literally, that's what it's called, programmed death receptor. I know it sounds ridiculous, but that's what it is. You have to have these receptors in order to get these medications. So, that's great and that's all scientific and really exciting for people like me, but what does it mean for people like you who are like, I don't really care about any of these scientific things? But it's important because when you're looking at a case, whether you're underwriting it or you're medical managing it or you're claim adjudicating it, you need to make sure that they have that mutation in order to get that drug because these drugs are expensive. So it's actually requiring more effort on your part to make sure that the therapies are right. Because it's not okay to say they have lung cancer and they're getting cisplatin and we always use cisplatin and that's totally fine. Now they're going to getting Xalkori. Well, do they have the right mutation for Xalkori or not? So you have to do a little bit more digging. So it's going to be a lot more work on your part the more that these things come out. Make sense? Not exciting, I know. Not happy either. So Anyway, so like I said, last year was 45. Of those 45, 39 were approved in the first cycle of review. That's a pretty high percentage. It almost feels like the FDA is rubber stamping things, but I don't want to go that far, but that's a pretty high percentage. And 27 of those were actually approved under an expedited time frame. So they're coming to market faster. So 1% of prescriptions written are for specialty drugs, but they make up 25% of a $263 billion drug spend. That's a lot of money. I would like to have 23% of $263 billion all day long if you would give it to me. So 63% increase are in patients who are on at least one specialty drug. And this to me was the most interesting statistic. If you're into statistics at all, you should find this fascinating. And if you don't, I can't help you. 31% of the increase in spend on specialty meds are in two categories: hepatitis C, which isn't all that surprising, and these compounded medications, which I know confound everybody. But they're basically taking medications that are FDA approved individually and putting them all together into pastes and different types of transdermal things, the things that go on your skin. And none of those are actually FDA approved, but they're using them. If you took those two categories out, the overall drug spend would have increased only 6.5%. So it's a big number. Those drugs are driving a lot of costs. And hepatitis C makes the most sense. Why? Because it's everywhere. Because there are anywhere between 3 and 5 million people in the U.S. who are infected with hepatitis C who didn't until last year know it. Why? Because it didn't matter if they knew it or not. We didn't really have great things to treat until basically 2013 when Olysio and Sovaldi came out. And then, of course, all of the other ones sort of followed suit. Harvoni, the Vicaripac, Tecnivi, Declinza, and I'll talk to you about Zepatier. So all of these people were never going to get treated because nobody wants to take interferon. It's really cheap. Oh, I'm sorry. Thank you. I'm sorry.
Time frame on your 63% increase and your 30.9.
Uh-huh.
What's the time frame on that increase?
That's over the past 5 years.
5 years.
Sorry. I didn't see you waving your hand. I'm sorry. So all of these people who were not going to take interferon because it's onerous to take and the side effects are terrible, now all we have to do is pop a pill. Sometimes only one pill, but you might have to do 2 pills a day. So now all of the drug manufacturers, I'm sure you guys have seen the commercials, have gone out and said, go get tested. Why? Because we can treat you. And you know, and we could, if this were hepatitis C talk, we could certainly talk about the pros and cons of that and how it truly is less expensive for them to take the pills, get rid of the hepatitis C than it is for you to have to deal with a liver transplant or cirrhosis or fulminant liver failure. But this is why the explosion has been the way it's been, is because these drugs are now easily available and easy to take. Patient compliance is everything, right? You can develop the best drug in the world, but if the patients aren't going to take it, your drug is going nowhere. So ease of use is a big thing. So all of these oral regimens make a big difference. We did this. So let's talk about price increases. So everybody knows Turing, right? We all know who Turing is. He's the Martin Shkreli guy who went and bought up all the rights to Daraprim, which is a drug used in various infections in HIV, and decided to take that price from somewhere in the neighborhood of $10 a pill to $13.50 actually, to an AWP of $750. I guess so he could buy apparently the Wu-Tang Clan's last album, which was $1 million. I mean, I don't know the Wu-Tang Clan, but I'm pretty not paying $1 million for it. So, and he smirks the whole time during the trials, which just makes everybody want to punch him in the face. So, but here's the interesting thing. We all know who he is, and we all know about Daraprim, and we all know about Turing. Do you know where AWP sits for that drug today? $900. So nothing changed. He's under investigation. I don't think he even runs the company anymore. But whoever's running the company at Turing, that drug sits at an AWP right now of $900. Nothing has changed. So there's a lot of hue and cry. There's a lot of articles, but nothing has really happened. So there are some companies that have developed sort of biosimilar drugs and are trying to take that market away from Daraprim. I don't know how successful that is or how successful that's going to be because that's kind of in the infancy stages. But Torig is not alone, and there are some other companies that you may or may not be familiar with who are just as egregious as he is. So Valeant, and actually we were talking, I know, on the plane today about Valeant. These are not the drugs that we were actually talking about, so I would love to know, Connie, which one you were doing. So Valeant Pharmaceuticals, they bought the rights to these two cardiac drugs, which is Isopril and Nitropress. So when was this? So this is in February. So the very day, literally, that they closed the deal on buying the rights to that medication, they hiked the prices by 500% and 200% respectively for these drugs. Now, these are vials, and so these types of drugs tend to be given as weight-based meds. So these prices may not seem terrible to you, but I guarantee you in terms of how much you have to give to a given patient, they're going to be very expensive. So Isopril itself went from $215 to $1346. That's a 500% increase. So, I know it's not $5,000, but it's still pretty pricey. And then Nitropress went from $402 to $805, or a 200% increase. Rodellis is another one. The drug is cycloserine, which is actually a tuberculosis drug. They went from $500 for 30 capsules to $10,800 for 30 capsules. And I have to be honest, I never really heard about cycloserine or kind of saw all of the hue and cry, but they got a lot of pressure, and Rodellis actually backed that down, and that price now for the 30 capsules is at about $1,000 or $1,100. So still a 200% increase, but nothing, obviously compared to $10,000. So it makes a big difference. So that's sort of the intro into the specialty drugs. And what I want to do is talk to you specifically about a lot of the drugs that have been FDA approved, what they're used for, what you should be looking out for, and things to keep in mind. So does anybody have any questions yet? No? Everybody's still with me? Everybody still awake? Yes. You in the orange.
Is Medicare covering any of these drugs?
They are. In fact, they are. But here's the thing. And people sort of ask me a lot about that. Medicare has a much different methodology, and we're actually going to talk a lot about that when we talk about some of the pricing. They are covering the drugs, but they have a cap in terms of what they can cover them at. So they have a Medicare payment limit, and their payment limit has been fixed for many years now at 106% of average sales price. The only wrinkle with that is that average sales price is actually reported by the manufacturer. But you'll see as we talk about some of these drugs that it's still very, very low. So a lot of their exposure with some of these things really is capped. But there are some drugs, and actually not an insignificant amount of drugs, where, and I know the folks after me are going to be talking about reference-based pricing, so I'm not going to kind of trample all over their types of things, but the one thing that I would tell you is that it's tough to do for Medicare to do sort of reference-based pricing with drugs that don't fall under specific J codes. So J codes are what we use to identify drugs, and every drug has typically its own individual J code, and they kind of track to a certain Medicare payment limit. But what happens with new drugs and even older drugs that just sort of have fallen into these unclassified categories is they have unclassified J codes. They're considered like there's a J code called 3490, and that's an unclassified biologic. And so Medicare doesn't have a payment limit for that because they don't have an ASP for that code because it encompasses so many drugs. And so what happens is it gets sort of left to whoever is administering benefits or adjudicating claims the local level for Medicare contractors. So they kind of fall into some of the same problems that we have where they can't really cap it, but they still pay a significantly less amount than you guys would see. So there's not, and some drugs they certainly don't kind of have any pricing with, particularly drugs that are for pediatrics. Not a lot of Medicare pricing information out there. So they kind of revert to some of the pricing strategies. So I love reference-based pricing, and I think it's a great thing, sort of despite the perils that you can have with the different facilities. And I know some folks from IU Health are here, and they'll probably be much more angry with the people after me than me. But reference-based pricing works for a significant amount of people, but not You can stay. So this is good. Like I was like, oh, they're going to be much madder at them than they are going to be me. I'm not going to be talking nearly about I'm not going to be bagging on the facilities nearly as much as they're going to be. Yes, I am. Yes, I am. So Medicare kind of limits its exposure much more than we get to kind of in this room. So you had a question?
It's related to that.
Sure.
When it's experimental before approved,
Yeah.
what does Medicare pay and what do they allow?
Well, that's interesting because what Medicare does is sort of what we should all do is they look at that. And if it's experimental, they may or may not cover it. So Medicare does have coverage policies for a wide variety of things, drugs, procedures, and treatments. So they will look at that and determine whether or not they're going to cover it. But here's the other thing that's sort of unique to Medicare that is not as unique, to us. So if you go into the hospital, for whatever, as an example, and you get a drug that's during your stay, and I can't really think of a great clinical scenario to kind of do this off the top of my head, so this is probably not the quality presentation that John was talking about earlier. But if you go in there and you get a drug that's experimental, let's say, in this room, when we adjudicate the claim, we go through that itemized bill and we say, you know what, this drug looks funny. We need to take a closer look at this and decide whether or not we're going to cover it. And we have the opportunity to pull that drug out and say we're not going to cover it. And then we can pay the rest at, some ridiculously low, PPO type of rate. But we feel good because we didn't really have to pay for the drug. Medicare doesn't look at inpatient admissions like that. What they do is they look at the first day of the stay and they say, did this person need to be admitted for whatever? And was that appropriate? And if that is, they look at that's it. Day one, and they don't look at the itemized bill because they reimburse typically on a case rate or a case rate plus outliers. Now, the outliers certainly do take into account what the charges are because you're looking at an outlier and it's sort of a percentage of the itemized charges. But if it's just going to fall into the DRG, because what can happen is the patient can be in for a very short amount of time and fall into the DRG length of stay, and it doesn't really matter how much the drug is charged because Medicare is only going to reimburse that case rate. So they don't look at the itemized bill. So they don't have, again, the exposure that you do. So they don't look as much in the inpatient realm, but in the outpatient sector, they do have a lot of coverage policies that do that. So, make sense? Not really. I know.
The whole system makes sense.
I know, the whole system doesn't make sense, so it's all a big mousetrap. Anybody have any other questions before we move to the drugs? Okay, good. Okay, so this part I'm going to sort of do, as Connie mentioned, in our directory so that I can show you. I'm going to go out of order. Actually, you guys don't even have copies of the slides, so you wouldn't even know if I was out of order, would you? But if you want copies of the slides, you can feel free to email me or email Connie, and I can get you a copy. So I want to show you the two drugs that I talked about, literally because so Lenvima was on Monday. Can you guys see this? Hopefully. It's not a big room. Okay. So Lenvima was FDA approved last year for the first thing, which is treatment of thyroid cancer. Thyroid cancer isn't as common, particularly in the venue in which you would be seeing Lenvima. So I don't know how many of you have even seen claims for Lenvima, but now you're going to see them because on Monday, it actually got FDA approved to treat renal cell cancer, which is kidney cancer. That's a whole lot more common than thyroid cancer tends to be. So here's the thing that I was talking about. And this is not because it's new, but you can see that the J code here is 8999, which is just oral chemotherapeutic, not otherwise specified. So there's no Medicare reimbursement for that. So if you're trying to do reference-based pricing and using Medicare as your benchmark for this drug, you don't have anything. So
106% of zero.
Right, exactly. Right. The average sales price is, well, nothing, so we'll go with zero. I'm guessing that the providers probably would not appreciate that. And I will not pick on the IU people and ask them that. So what we've sort of done is to talk more about the way we sort of define these things is what would be reasonable to pay. But before we do that, let me tell you a little bit about the drug. So it's an oral drug. It's easy to take. It's 18 milligrams once a day. It is given for patients who have advanced or metastatic renal cell cancer who have been on one prior, something called anti-angiogenic, just ignore that, therapy. But what's important for you to hear is that it's after something else. it is not first-line therapy. So if you're looking at a claim, or if you're in an underwriting situation or a medical management situation, and you see this drug, it literally got FDA approved Monday, so unless you saw it yesterday, you probably haven't seen it yet, but you will. It's an oral drug, so it might run through maybe a PBM, so you got to look at the RX types of things, particularly for the underwriting, but it's most important to know that it's not first-line therapy. So if your patient has just been diagnosed with metastatic or advanced kidney cancer, this is not the first drug that you should see. And where are you going? What are you doing? You can't leave. So you got to look at these things. It is oral. It's 18 milligrams once a day. They might come out with an 18 milligram tablet, but right now all they have really are 10 milligram tablets. And then they actually have 4 milligram tablets, but they're in packs with the 4 and the 10 because of how it's given for thyroid cancer. So the actual just single 4 milligrams aren't even to market yet, but I'm guessing they will be in the first week. So they take 1 10 milligram tablet and 2 4 milligram tablets to get their 18. And they take that once a day, every day, forever, until they either have disease progression or they can't tolerate the drug. So this is something that you're going to see ongoing month after month, year after year for, as long as the patient can tolerate it and it's working. And again, I'm a physician, so I have to put on my physician hat and say, the drug development of drugs is great if we're prolonging survival, overall survival, disease-free progression, good quality of life. That's a good thing. And then I have to put on sort of my cost containment hat and say, well, what is that worth? And, over actually in Britain, they actually have cost effectiveness meters where they look at drugs and they take that into account before they actually approve it. We don't do that here. We don't, if the difference is survival of 1 month versus 3 months, in Britain, that makes a difference. 1 to 3 may not be enough for them to actually go ahead and approve the drug. Maybe 1 to 6 might be, or 1 month to a year might be. But, we kind of take that out. I think people kind of hear that and they think now we're back to the Sarah Palin death panels. But this is what other countries actually do. So what does that mean for you? Well, that means that you're going to, year over year, see these types of costs. So what are the reasonable costs? This is sort of an estimate because, like I said, the 4 milligram tablets aren't out as an individual pack. So we did some sort of regressive math on the packets that it exists in. So I think this is going to be pretty close. I don't think it's going to be much different. So a 30-day supply of an 18 milligram dose reasonably, this is reasonable, this may not be what a provider charges you, could be higher, could be lower, is $57,000 for a month. Now, how do we come to reasonable costs, you might ask? And that's a great question, and that's what I'm going to tell you before you actually ask me. So what we do, I know, it's crazy. What we do is we look at 4 different benchmarks. We look at average wholesale price. We look at wholesale acquisition costs. We look at average sales price if it exists, which obviously in this case it does not. And then we look at something called the NADAC, which is the National Average Drug Acquisition Cost, typically used in sort of a more retail pharmacy type of setting, but it aggregates all sorts of pharmacies across the country. We average those all out, and then we run them through an algorithm that we use on reasonable and customary audits to give you what reasonable costs are. And we think it's a pretty fair reimbursement. It's not 100% or 106% of average wholesale price. It's not 400% of average wholesale price. We try to take a bunch of different parameters and do this. But nonetheless, at $57,000 reasonably a month, you're looking at somewhere in the neighborhood of $700,000 a year for this drug. And this is after they've been on something else, which may be in the existing policy period. So you may need a laser of $1 million for a patient who now has kidney cancer, which you might not have ever thought of before. Although, I will tell you, and I'm just going to switch real quick out of this for 1 second. Just to give you an idea, there are a lot of other drugs on the market. This is the disease portion. So there are a lot of drugs on the market, and then these sort of give you the reasonable costs. They run anywhere from, say, $20,000 to a drug called Inlynta, which is not used tremendously, but that's upwards in the neighborhood of $52,000. And most of these are for sort of the same types of scenarios, metastatic disease, but some of them are first-line therapy. So right now, reasonably, kidney cancer should concern you unless it is very, very early. Unless it is simply stage 1 and they take the kidney out and they need no other therapy, you should definitely be looking much more closely at kidney cancer than we may have in the past. And this drug will only serve to actually increase the concern that we would actually have. So that's Lenvima. Anybody have any questions on Lenvima? Yes? Ed.
When you look at the average wholesale on the various prices, you also compare that specialty pharmaceutical to the Canadian prices or European prices?
No, because we're not really doing them as a comparison. We're giving people what reasonably they should be seeing in the U.S. Yeah. I mean, if we started to look at Canada and Europe, I mean, the reasonable cost would be much, much lower. They get particularly the hepatitis C drugs. You would die if you know what Sovaldi is going for over in, say, Germany. It's practically pennies on the dollar for what they're getting. We just, we're sort of what the free market will bear. We don't really have any ability. From the government standpoint, Medicare is not allowed to negotiate, the prices. Like I said, they reimburse this fixed cost of 106% of average sales price, but they don't set average sales price. The manufacturer sets average sales price. So that kind of fluctuates depending on, the given drug. Some are higher, some are lower. But that's how the only way Medicare really has to do cost containment is to set a cap of a percentage they're going to reimburse on. And that, like I said, has been consistent for at least 5 years. It may go higher, it may go lower at some point, and they are looking at their whole payment system, so who knows? Yeah?
At what point does a drug go down in price, or does it ever?
That is interesting. They do go down sometimes, but those tend to be the drugs that you don't care about. And sort of, they do. Like Tylenol goes down. We're like, woohoo, who cares, right? But some things do and some things don't. And I'll sort of give you a classic example. You may all be familiar with a drug called Gleevec, sort of a life-saving drug for folks who had a particular type of leukemia called CML. It was great. It came out something in the neighborhood of, say, 10 years ago. And basically, patients will take this drug indefinitely for the rest of their lives, and it keeps them in remission. And if you go out of remission, unfortunately, with CML, your option is a transplant. So it's a great drug, and it's a life-saving drug. And when it first came out on the market about 10 years ago, average wholesale price for a 30-day supply was somewhere in the neighborhood of $4,000. Now, there's a lot of other drugs on the market now for CML that you can use either after Gleevec or as a first line, et cetera. So you would think, well, now there's competition and the price is going to go down. Yet, average wholesale price for a 30-day supply of Gleevec stands right now at about $11,000. 10 years later. So it's funny. It's tough to predict, and we update, for PredictRx, we update our prices pretty much on a quarterly basis, unless something extraordinary happens, like, Daraprim, we all obviously scrambled to update that. But we pretty much update them on a quarterly basis, and things don't change all that much. And I would say the percentage of things that tend to go down in terms of what AWP or the WAC or ASP really look like is maybe 20%. It's not a lot. It's not a lot. And here's more bad news. I am just full of bad news for you today. I know you're so thrilled that I'm here. Here's more bad news. So what used to happen is there was patents on drugs, right? And when did the patents expire? 5 years, right? Do you know when the patents are now going to expire? 12 years. Why? Because this is what we're doing. We're bringing these drugs to market sooner, so they need the studies to confirm that they can stay on the market, and then, of course, they need the time to keep the patent intact to recoup all of the R&D costs. And so what happens during that patent time, what happens when a drug goes generic, right? It's cheap as anything. It becomes really, really cheap. But the longer they get to keep those patents, the longer they don't have to kind of reduce the price of the drug because it doesn't go generic. So 5 to 12 years is a big difference. I mean, we all can do the math. I know it's 7 years, but 7 years in the life of a drug and drug development is a really, really long time. Okay? Yes? Oh, it's okay. I never planned on getting through all the drugs, so.
When we're looking at drugs, our medical management department, people who are currently on maintenance drugs, and we're trending them out for the next year, we're looking at an average of 8 to 11% is usually what we set
Yep.
to up the cost of the drug.
Yeah.
the next year. Is that fair?
I would say that's fair, sort of overall. But there, like I said, there are some drugs. There are some drugs like the hepatitis C drugs. They are priced so high they don't move. They just don't, because everybody is like, oh my God, $1,200 a pill for Sovaldi. Like that's it. The market will bear $1,200 because that's what the New York Times says the market's going to bear. Well, see, those I would say that 8 to 11 is probably good for your cancer drugs, some of your more rare drugs, but anything where you see competition with a lot of things, and there are more and more RA, and I could show you RA, there's more and more drugs that come out, you're not really seeing that. They're kind of stagnant. You're maybe within 3 to 4%. So I think you probably need to look at it in terms of what's the category. I would definitely say for the cancer drugs, yes, because new things are coming out all the time and everybody is just trying to keep up. And also the big thing, again, as I mentioned with the cancer drugs, is that they're all coming out as first-in-class drugs, right? So today's Lenvima, or Monday was Lenvima, yesterday was Opdivo for something else, and they're totally different classes for totally different cancers. And even within cancers, you're getting different receptors. So everything is new and novel, and so now you don't really have anything to benchmark it against other than, I have this, which is sort of similar, and I can't really price it more than that. But if I don't have the mutation, it doesn't matter. So I guess that's a long-winded way to say that I don't know that I can generalize. That would probably be the best way to say it. Okay, good. Anybody have any other questions? Great. Everybody having a good time? Okay, good. I'm having a great time. So yesterday's drug is Opdivo. Are you guys familiar at all with Opdivo? I see lots of commercials for it, so I thought, this might be something that you're seeing. So Opdivo is another fabulous cancer drug. And up until yesterday, it was FDA approved for the first 4 things. Most of the time, most of the commercials, for whatever reason, seem to be focused around the lung cancer, the non-small cell lung cancer. But it is FDA approved for melanoma, non-small cell lung cancer, kidney cancer. And then yesterday, it actually got approved for for Hodgkin's lymphoma. So let's take a look at this. Okay. I'm just going to scroll down. I'm sorry that it's small. I have no idea how to make it bigger. I guess I could make my screen bigger, but I don't know if I can do that for you right now. Maybe I could zoom. Does that help? Oh, that's much better. So why didn't somebody tell me this earlier? Now you're all going to talk about me when I leave. Okay. So Opdivo, this is a good drug because it has a J code that Medicare can reimburse on, right? So it's J9299. All Medicare things are all the generics, so don't even try to pronounce them, by a certain milligram. So Medicare's payment for this is $25.37, but that is per milligram. And this is a weight-based drug, so you have to sort of do the math. And we do the math for you in this. So when should this be used? I'm going to just scroll down. So it's for classical Hodgkin lymphoma. Again, for any of you anybody here clinical other than me and Connie? Anybody nurses, doctors? No. Okay, forget it then. So for Hodgkin lymphoma, it's enough to know there's different cell types and different types of things. One is called classical Hodgkin's lymphoma, right? The person needs to have classical. It takes a little more research on your part to figure that out, but you're going to want to do that when you see how much this drug costs. So it's relapsed or progressed after they've already had a transplant. You have already covered the transplant, and they've had another drug after transplant called Adcetris. Okay, so they have to have classical Hodgkin lymphoma. They must have gotten a transplant, so you should make sure that they've actually gotten a transplant. And they have to actually have Adcetris before they can be on this drug. It's a lot of criteria. It's a lot of restrictions. It makes a difference. It will also make a difference in terms of the cost, because all of that could happen in 1 year. Particularly for Hodgkin's lymphoma, if you get to the point where you need a stem cell transplant, you could, in theory, have the transplant. You could fail the transplant immediately. You could relapse or progress quickly. You could be on Adcetris. It could not work in 3 months, and then you could be on this drug. That's a lot of cost all in 1 year. So some of these things can be spread out, but some of these things are very, very tight and very, very close and can be really accelerated. This is one of these things that actually got accelerated approval, and so we just make a note that now they have to verify that through the clinical trials. So I don't know, will Opdivo still have it next year? I don't know, you'll have to invite me back again and we'll talk about them again. But I don't know, we have to wait and see what the studies show. So how do we give this? Well, we give this drug, it's 3 milligrams per kilogram, as I mentioned, every 2 weeks until disease progression or unacceptable toxicity. In the catastrophic claim world, those are words you definitely don't want to hear. What that means is indefinite therapy, which we sort of noted there. It's chronic and indefinite. So the average male, in medical terms, if you are looking at cases and you don't know how to figure out what you might get, what we typically use standard in the medical community is a 75 kilogram person. So it's 3 milligrams per kilogram. You have a 75 kilogram person, and then that tells you how much of the drug that they're actually going to need. But we've done all that math for you. So the vials only come in 40 or 100 milligrams. It is important, at least for me, to tell you that these are single-use vials. So what does that mean? So this means if you calculate out a dose for a patient and they need 3.5 vials, you are going to get billed for 4. Why is that? Because they have to waste the last half of that vial because it is single-use. That means once you open the bottle, you cannot put it back in. It's not like the genie. It cannot go back in the bottle. You can't refrigerate it. You can't use it again. So if they only need to use even 1/8 of a vial, you're going to get billed for the whole vial because it's single-use. And unfortunately, that's appropriate to do because that's how they have to buy it. That's how the providers have to buy it. So if you're in the middle, you got to round up to the next vial. That is not the case if it is a multiple dose or a multiple use vial. That means it can be reused again. So you take or you draw off what you need, and then it can be refrigerated for that patient for another dose that they need. In that case, you should only be billed for the dose the patient is actually being given. This might sound like nuance and sort of small stuff, but I guarantee you when you see some of the vial prices, the difference between a half of a vial and a full vial can be several $1,000s. So it does make a difference. And so it is important to check that in claims adjudication. So in this case, like I said, we've done all the math for you, 3 milligrams per kilogram. They get it every 2 weeks until disease progression. Reasonably, this drug will cost you $403,000. That's after the transplant, and that is after Adcetris. So that could be Hodgkin's lymphoma. So you're going to look at your Hodgkin lymphoma people, particularly if they've already had a transplant and you're underwriting them for relapse or progression, your lasers are going to have to be a lot higher. It just, like I said, this just happened, so we don't know what providers are going to charge. It may be less, it may be more. We just really don't know. Some providers are good and stick close to average wholesale price, and others charge, like Turing, as an example, marking it up. They can mark it up significantly as well. The hepatitis C drugs are they're an entity unto themselves. And why is that? Is because when Sovaldi came out, there was this insane frenzy. Every one of you probably knows about Sovaldi and has heard all of these hepatitis C drugs, and it was crazy that it was $1,200 a pill. I can tell you there's at least 50 other drugs that are as expensive, if not more expensive, than Sovaldi. But hepatitis C is fairly common, and so we care about it because there's a lot of people infected with hepatitis C. We don't care about it so much for the more rare diseases. And so what happens is, bizarrely, sort of this almost public peer pressure has kept those hepatitis C drugs running around average wholesale price when you see them. So when we talk, our directories, we don't make that distinguishment at all in terms of calculating the reasonable cost. We still calculate our reasonable cost based on the benchmarks that I mentioned, but we do make a notation that pretty much for all of those hepatitis C drugs, starting with Sovaldi and kind of ending mostly with Harvoni and the Vicaripac, they're really running at that AWP level because providers who are giving them in pharmacies, they just don't want to take more of the heat that they've been getting for the hepatitis C drugs. So you're kind of getting a break with that. And like I said, last year was sort of the year of hepatitis C talks for me. And every talk I was at, I said, my concern is what happens when I come back to talk to you next year when we've moved on to something else. And believe me, we have moved on to other things. We have moved on back to hemophilia, back in the day. We are on to hemophilia again this year. And hepatitis C is kind of like, it's sort of happening and not too many people are talking about that. And I was curious to sort of see where pricing has gone, and interestingly, it stayed the same. Everybody is sort of staying with charging around that AWP price. So it'll be interesting to see, is that going to be the norm, that as more of these drugs come out for whatever, hemophilia, et cetera, that the public pressure and the public scrutiny and sort of this 24-hour news cycle that we experience, is this going to make a difference in terms of the drug costs that you're going to see? And that maybe next year I'll be telling you how I've rearranged and we've recalculated what reasonable cost should be kind of based on this. It's not happening for other drugs, just so you know, but hepatitis C definitely overall has had that impact. So it's still running really about 50% of what we would expect to see in terms of reasonable costs. Well, I can tell you that. Here we go. So it is only for, again, I know none of you guys are clinical. There's two types of lung cancer, though. There is non-small cell lung cancer, and there is small cell lung cancer, and they are different things. So you need to make sure that they have non-small cell lung cancer. So that's sort of rule number one. So the dosing is exactly the same. It's 3 milligrams per kilogram every 2 weeks. So reasonable cost for Opdivo for lung cancer is $400,000. I think the dosing is pretty. Let me just check real quick. Melanoma. Yep. It's a weight-based drug. So it. But here's the thing. And again, I know, Tom, you're totally not clinical. But here's a lot of parameters, right? For non-small cell lung cancer for this drug, it's patients with progression on or after a platinum-based chemotherapy. So they have to have had some type of platinum, carboplatin, cisplatin, something with a platin in it. It's a single agent, and it's for two different types. There's squamous and non-squamous. So, I mean, it's a lot of boxes to check. It's a lot of work to do to make sure that they're appropriate. Now, I will tell you, manufacturer, their reported cost for a full year of treatment for this is $150,000. We are not seeing that. That is not what we are seeing. We are seeing much higher costs for Opdivo. At least that's what we're seeing. I don't know what your experience has been, but I mean, I know I live in a different world where the claims that come to me are because they're catastrophic. So we are definitely not seeing that anywhere near that $150,000. And then we just tell you a little bit about kind of how it works. So it's an expensive drug. And it's definitely, it's getting more and more play and more airtime, and there's a lot of direct-to-consumer marketing for it. I mean, I live outside of Philadelphia, and so I see it sort of all of the time. Direct-to-consumer, just to digress a little bit, and then we can do one more drug. Can I do one more drug, and then I'll go? Okay. Actually, maybe two more drugs, because they're hemophilia, and I know we want to talk about hemophilia. And maybe the hepatitis C one. All right, so maybe I shouldn't digress on the story. All right, so let's talk about, all right, I'm going to skip multiple myeloma, which will kill me. So there's another drug for non-small cell lung cancer. It's kind of like an auction. Tell me what you want to do. Okay, hemophilia A. You want to do hemophilia A? Yes, of course. Okay, so this drug is Adenavate. I don't know if you're familiar with it. Pretty much if it ends in an 8, it's for hemophilia A because it's factor VIII deficiency. So this drug was actually FDA approved December of last year. And so it is indicated for most of your typical things for hemophilia A. So basically for bleeding episodes as well as routine prophylaxis. It is important to note that it is different from a lot of the other hemophilia drugs is that it is not used for what we call perioperative management. And what that means, either pre-op or pre-surgical or post-surgical, you give factor VIII to make sure somebody doesn't bleed. It's not that they've had a bleed during the surgery, but somebody who has hemophilia A, which is factor VIII deficiency, if they're undergoing any types of procedures, whether it's major surgery or minor surgery, you give them factor VIII preoperatively, post-operatively, and sometimes like up until a week or 10 days later to make sure that they don't bleed. This drug does not have that indication, though. It's only for a bleeding episode or, this is the killer, routine prophylaxis. And so it is only for congenital hemophilia A, not acquired. That makes a difference. So you need to check that out. And it is not for von Willebrand disease, which is sort of a milder type of bleeding disorder. So I'm just going to focus a little bit on routine prophylaxis because that's the killer in terms of the expense. So the important thing to know for this is that if you have severe hemophilia, and I will tell you 60% of hemophilia A patients fall into this category. The vast majority of patients with hemophilia A have the most severe disease. And what that means is that their factor VIII circulating level is less than 1%. And so what you need to do is to give them prophylactic treatment so many times a week to keep that circulating factor VIII level greater than 1%. And it requires a lot to do that. And there are a lot of drugs, Advate, Helixate. There's literally 20 drugs for hemophilia at this point. But Adenavate, and there's actually one other one called Kovaltry that actually came out in March of this year that were supposed to be sort of longer-acting drugs and that you didn't need to give them as frequently. And so in the theory and the thinking would be that would cost you less, but it turns out it probably isn't going to cost you less. Now, on the surface, it doesn't look too bad. It has a J code, very similar to, I will tell you, it's some of these J codes for hemophilia drugs are not specific to individual drugs. They kind of all fall into certain things. Some are specific for the drug. But the Medicare payment limit, this doesn't look so, this looks great, right? It's like $1. I could throw $1 out the window today. That's totally fine. It's $1.18 per international unit, though. It's a weight-based drug, and you have to give it so many times a week. But Medicare pays about $1.18 per unit. Our reasonable cost calculation, this still doesn't look too bad, right? It's $3.65. You know where I'm going with this, right? This isn't like, I'm not building it up to give you nothing, of course. So reasonable cost per international unit doesn't look so bad. It's $3.65. As I mentioned, it's a weight-based drug, and so the way that it's given is 40 to 50 units per kilogram twice a week, which is a much longer acting drug than some of the other earlier drugs that are out there, which you give 3 to 4 times a week. So, and it's for kids greater than 12 as well. Hemophilia is what you tend to see the most severe disease in young kids. This is not indicated for very young kids. This is for kids older than 12, so that does make a difference. But you give 40 to 50 units twice a week, which is less time overall than the other drugs are, yet reasonable costs if you're an adult are $1.3 million. That's reasonable. That's reasonable. That may not be what you see. There you go. See? Well, you're almost reasonable. you're just a little bit above reasonable. Right. So that's reasonably what these patients will cost you. That has nothing to do with what you might see a year after year after year. Now, that's $1.3 million. The last claim that I did, I'll show you this real quick, was for a patient who was in the hospital with hemophilia, had a bunch of different drugs, including this happy little drug right here at $143,000 a dose, which, by the way, is actually not that far off of reasonable for that particular drug, just so you know. With the PPO discount, this drug fell into UCR, just so you know. This admission, the person was in for a bleed, just for a bleed. They had something called a retroperitoneal bleed, which is bleeding into the space back here. Seriously, all he did was literally bump into a table. No major trauma, but that's a tough space to bleed into. It's tough to contain. He was in the hospital for about 30 days. They continued to give him all these factor drugs. I will tell you the vast majority of these turned out not to be medically necessary because once he had stopped bleeding, they continued to give them to him anyway for a different reason. But 30 days in the hospital, please, can somebody just give me a guess for the billed charges? 3.5? No. $9 million. $9 million. 30 days. So when we're talking about reasonable costs of 1.2 in a year, that may not be what you see. And he wasn't even on prophylaxis. So $9 million. Oh, and it turns out that this drug, even though it's within UCR, wasn't medically necessary because he didn't have congenital hemophilia. He had acquired hemophilia. So, yeah. Well, that was sort of why we saw the case, to kind of do the medical review on it, et cetera. So the other new drug that came out for hemophilia A is a drug called Kovaltry. And that was actually FDA approved in March of this year. It is for all 3 things, so bleeding management, perioperative management, pre and post surgery, and then routine prophylaxis. Not indicated also for von Willebrand disease. again, the prophylaxis is kind of the important thing. This also falls into the same J code of that 1.18. This prophylaxis is 2 to 3 times a week as well. 20 to 40 units, 2 to 3 times a week. This is used in children under 12, so you will see that. Their costs tend to be less simply because they weigh less. So as they become adolescents, you start to see more of the adult dosing. So reasonable cost for this, $1.3 million. So they're about the same. They came out about 4 months apart. For kids, it's a little less, again, only because of the weight. It doesn't have anything to do with the price of the drug. It's just because they weigh less, and so there's less dose that you actually have to give them. So hemophilia is the 2016 hepatitis. I don't know why. We all talked about hemophilia maybe 5-6 years ago. It's back, though, with these 2 drugs. I will tell you, there's another drug out there called Idelvion, which is for hemophilia B, which is congenital factor IX deficiency, so that's obviously a little bit different. It's much more rare than hemophilia A, which is why I chose only to talk about hemophilia A today. But it's out there as well, and it looks just like this for hemophilia B. So that's 3 new drugs within 4 months for hemophilia, so it is back. Yes? The drugs for multiple myeloma?
If you don't mind, just 1 or 2.
Well, I don't mind, but you tell me when I have the hook.
Hemophilia B Christmas disease?
It is. It's actually, the guy's name who discovered it was actually Christmas. Lucky him. So, yeah. Merry Christmas.
There's 3 different levels of it, correct? A 1, 2, and 3?
No, not really. Again, it's the same type of thing as hemophilia A, where it falls into mild, moderate, and severe. And it is also the same type of thing where the largest population has the most severe disease, right? And hemophilia B tends to, hemophilia A is much more likely to have inhibitors, if you guys are familiar with that term, inhibitors. All that means, it's literally exactly what it means. It inhibits the factor drug that you're giving from doing its job. So it prolongs bleeding and it makes more severe bleeding. So what do we have to do? We have to give anti-inhibitors. And what they are, they're bypassing products. So they bypass the inhibitor so that the clotting drugs can work. And just to give you an idea of where that falls.
What are the inhibitors costing?
Yeah. So this is one of the inhibitor drugs. This is called FIBA. The 2 anti-inhibitor drugs, not inhibitor, anti-inhibitor drugs, bypassing agents, are basically FIBA and Novo7. Those are the 2 drugs that we use. So I know that this claim is 4 years old, but it's so impressive that you just have to see it. So consider that these are the charges actually 4 years ago. This is for a single date of service, literally for 50 units, for 992 units of FIBA, a one-time dose was $148,000. One time. And anti-inhibitor drugs you have to give ongoing until the inhibitor level either drops or you keep giving that so that the clotting factor can work. You don't keep giving the clotting factor, though, in the presence of a high inhibitor. So, like I said, you got to have a lot of clinical support with these things. There's a lot of nuances with hemophilia A and B, but more so A, just because 80-90% of hemophiliacs are hemophilia A. So, okay. So, multiple myeloma. So there were actually a few drugs. I only picked one. There were several drugs 3 drugs actually that came out literally 2 weeks apart in November of last year. But I was going to talk to you a little bit about Darzalex. If you have any of you heard of this or seen it? No? Great. New information. So it's multiple myeloma. It was actually given an orphan drug designation. I'm beginning to think that the only reason to give an orphan drug designation at this point is just to get more research dollars for the manufacturer, because there are so many treatments out there for multiple myeloma. But it is the only indication that it actually has. Again, it's one of these drugs. It's an IV drug, but it falls into just an unclassified category. So there is no Medicare payment for this. So, if you're trying to figure out how to reimburse for it, you've got to use something else, obviously, than Medicare as your reference. So that's why we kind of developed this to sort of give people the reasonable costs. So this was FDA approved in November of last year. Again, it's for multiple myeloma. It is a monoclonal antibody directed against something called CD38. I know, nobody cares. So it's meant to be given as a single agent. So good news, because you only have to pay for this drug and no other drug with it, so it only should be given by itself. Okay? So bad news is it's fourth-line therapy, which means they have to have had 3 other treatments before they use DARZALEX, and have failed those 3 treatments, obviously. And there are certain criteria in terms of what the drugs are. Again, a little too clinical for sort of this talk, but it needs to meet this criteria as fourth-line therapy in order to be given. It is single agent, but it will be given for as long as the patient can tolerate it. And it kind of has a schedule where it's given once every week for 8 weeks, then once every other week for 16 weeks, and then it moves to once every 4 weeks, again, until the patient progresses on that. So you may have 3 other treatments within that policy period, or I guarantee you're going to at least have 1, maybe 2, if not more. It does take some people either, if they can't tolerate it, you sort of know right away. But sometimes it takes a while to obviously have disease progression. That's sort of how cancer drugs, unfortunately, is that they work for a certain amount of time and then they stop working. And then you kind of have to move on to other things. So this one, I should have saved the hemophilia for the end, because this probably doesn't look nearly as terrible. But reasonably, it's not $1.3 million. Woo! We're down to like $275 for that. But that's a reasonable cost for this drug. It is an intravenous medication. This really is only the cost for the drug. There's going to be obviously labs surrounding it and the physician visit and kind of the other things, but they tend to be really nominal compared to the cost of the drug. So that's what's going on. If you guys are willing, I will do one more drug just because it's the hepatitis C drug. And if you don't want to, feel free to tell me that you're done and tired of drugs.
Best friend's mom was on that, and she actually passed away 2 weeks ago, and it had a horrendous effect on her heart, and she actually died of a heart attack.
Yeah. So, these drugs are not, we're not even getting into that, but these drugs are not without their side effects and their problems and their complications. And in fact, some of their complications can outweigh their yearly spend as well. Certain types of things. If some of these drugs put you into renal failure and you go on dialysis, that's kind of the ball game in terms of cost, because that's going to be ongoing, particularly because these are patients who are going to have an active malignancy, which means they're not going to be candidates at all for kidney transplants. It makes a big difference. And even the ones that are oral, it really just is not as simple as, we pop a pill and, we're good to go. They do have a lot of effects, and, that's a terrible, terrible outcome, for somebody who had already suffered, so much. I don't know that bringing these drugs to market faster is a good thing. I don't know. I think it's good that we're evolving, and, everybody's talking about the moonshot and curing cancer. And if you ever want to have a drink with me, I'll tell you my thoughts on whether we're going to cure cancer or not. It's a good thing to reach for the stars, but there's real people involved in taking these drugs, and there's real side effects and real complications, and it does make a difference. And quality of life is a huge indicator for us. Okay, last drug, I promise, and then I, honest to God, will let Ed talk. Really, although he told me at lunch he only needed 15 minutes, so I don't know. I think he's backing out on that promise. So, okay. So the last drug that we're going to do is Zepatier. This is the latest and greatest. Didn't make a big splash, interestingly, so we'll have to... Have anybody in claims seen this yet? Yeah, okay, a few people nodding. Didn't make nearly as... Harvoni is kind of the one that's making the biggest splash right now. We've moved well off Sovaldi. Nobody cares about Olysio at this point. It's pretty much all Harvoni and Vicarapac. And I didn't even put those up there, but they, in the past 3 months, have had additional approval for indications within hepatitis C, different genotypes and different circumstances. So they're getting more widespread. So Zepatier came out January of 2016. It is only for genotypes 1 and 4, so makes a difference. I will tell you that somewhere in the neighborhood of 2/3 to 3/4 of patients diagnosed with hepatitis C fall into genotype 1. So, it's the drugs that are for 2 and 3 and 4 that aren't 1 that you sort of probably need to pay a little bit more attention to. I would say, my thing is always make sure, but if you absolutely positively can't get any records or any information about the genotype, and it's a drug that's being given for genotype 1, 75% of the time you're going to be okay. So that's just kind of the general rule of thumb. Again, it's a prescription drug, non-chemotherapeutic, no real J-code, no set national Medicare payment limit for it. And it's a specific type of inhibitor. Again, I know you don't care, but it's important for the next piece. It's an NS5A inhibitor and an NS3/4A inhibitor. And patients who have a specific subtype of there are subtypes of genotype 1, just so you know, 1A, 1B, non-specific. But if you have 1A, they should be tested for NS5A resistance before you give this drug. So just more things to look at and more things to take into account. And that will help determine the dosing and the regimen in terms of what they get. It is typically given with ribavirin, which is an oral drug, so just another pill that the patient has to take. Most people tolerate ribavirin pretty well, and it's very low. I wouldn't say very low dollar. Maybe somewhere in the neighborhood of $4,000 to $8,000 a month, depending on how much they're taking. So it's not terrible in terms of the other things that we're talking about. I know. So here's how it's given. It's a lot to look at, I know. But again, there are different genotypes within genotype 1, whether they've had treatment before or they haven't. There's a huge body out there called the AASLD, which is the American Association of Liver Diseases Society, something like that, of liver diseases. They're the governing body for hepatitis at this point. What they sort of say sets the rules. They are not always in line with the FDA approval. They tend to be further along than the actual FDA approval. Are you taking a picture? I'll send them to you. Just give me your card. I'll show you the slides. Yep, I'll send it all to you. I know, I'm sorry, I'm not doing it through the PowerPoint. But yeah, I mean, feel free to take the picture, but anybody who wants the slides, I'll send them to you. So I was in a pageant just recently. So I was like first runner-up. So it was very bizarre. No, I'm like 47 years old and somebody asked me to be in a pageant. So anyway, it makes a difference whether you're treatment naive, whether you're treatment experienced, whether you have cirrhosis, whether you don't have cirrhosis, what subtype you are. Literally, there's a laundry list of things that you need to do for hepatitis C, which tells you how long and how often, and with or without ribavirin, that the patient is going to actually need to get the medication for. I will tell you, this is the FDA-approved dosing here that we have. We have the notation, as of this month, right now, the AASLD supports this dosing, and they don't have different dosing for it. So if you see something that's different, it's not going to be supported by that body or the FDA. So something to think about before you decide to reimburse. So it's acute and finite therapy. It goes, you can see, anywhere between, say, 12 weeks or 16 weeks of therapy. And the reasonable costs for a 12-week course of therapy is about $120,000. So I think we started at $1.3 million, we dropped to $273, and now we're down to $120, and you're all like, $120, big deal. But it's only for 3 months, But that's the thing with these drugs. They're only for 3 months, unless you're getting Sovaldi and you're a liver transplant patient, in which you get it for 48 weeks or until the transplant happens. These are acute and finite therapies. And reasonable costs, again, are $120,000. The costs are running closer to AWP, so you have to actually cut that, I would say, a half to 2/3. I don't know if the manufacturer said, Merck, who's the manufacturer, said that it would cost about $54,000, and that's where it's running. So $60,000 to treat hepatitis C, which can give you liver failure and cause you to have a liver transplant, which is a whole lot more expensive and fraught with way more complications. This drug doesn't look so bad. And I would tell you, that's sort of the same way you should look at the other hepatitis C drugs, even the Sovaldi's and the Harvoni's and the Vicaripax. The success rate, what we call sustained viral response rates for those, are almost 100%, which means these people are not going on to either A, become cirrhotic, or B, need a liver transplant. And that's good news for them, and that's good news for you. So I would say, we kind of all got hysterical about hepatitis C, and I never really quite understood it because overall, the costs really are not terrible in terms of what the alternatives are. Yes?
Isn't this just going to be mostly a wave effect anyway, as people go through and realize they do or do not have
Well, that's interesting. It mostly because, I mean, yes, you're going to kind of sort of have the upfront rush of people who are either undiagnosed or have it and don't know it, undiagnosed, or were diagnosed but couldn't tolerate it. So you kind of get that first wave. But so what's the most common way to get hepatitis C? Right, IV drug abuse. I don't think that's going away anytime soon, And when I gave this talk, some people were asking me about, well, what can, as an employer, what can I do to sort of prevent this? Wellness programs that we put into place for other things. You're not going to do a clean needle sharing program in your, like in your widget factory. You're just not right. It's just not. I know. Yes, it's like yeah. Here's your apple, your rice cake bar, and here's your clean needle. So. I don't think we're going to, unfortunately, run out of the supply of IV drug abusers. Another really bizarre way, actually, is through the inhaling cocaine through a straw and then sharing the straws. So I'm not all that familiar. So I don't share my straws, I guess. But the nose is fraught with areas that can bleed. It's very, you guys know if you've ever been hit in the nose, how easy your nose can bleed. It's very, what we call friable and fragile. And so if you're, using it and, you don't flip the straw and you give it to the next person, it's very easy to infect yourself with hepatitis C. So yes, I do believe that there's sort of this big first wave. I don't know that the second wave is going to be all that much smaller. Yeah.
How much is that first wave attributed to Medicaid expansion and all the males that were Medicaid eligible now that they were drug abusers doing this stuff their whole life? They
yeah.
I have a friend in Ohio that works for the state, and they said they can't even believe the numbers of the Hep C treatments coming through the Medicaid population.
It's interesting because that percentage is probably far less than you would think. I don't have actual numbers, but the vast majority of, I guess, closet, for lack of a better term, IV drug abusers are people sitting in this room. They're people sitting in this room. They're people with good jobs, with good health insurance, who are recreational IV drug abusers. They're not the people that you see, sitting on the streets, and homeless anymore. It's white, suburban, upper middle class, mostly male, just because, for whatever reason, I guess you guys tend to use drugs more than we do. We self-medicate with wine, apparently. We all have liver failure, but not from hepatitis C. So I'm a vodka girl, so I don't know. But so I don't know. I don't know what the number is, but I would tell you that the clinical statistics sort of don't bear that out because it tends to be people with very good paying jobs who are recreational users.
Well, they're like looking at Medicaid population.
Right.
So you don't know about the other stuff.
Right, because those people are not stepping forward. So anyway, it's almost 3:30, and I definitely want Ed and Ryan to have their time. So if I unfortunately have to fly back today, mostly because I'm going on vacation on Friday, so feel bad for me. But I will be here for a little bit if you have other questions. And certainly if you want the slides, I'm happy to send them to you. Feel free to give me your card. I can give you our card. And if you have any interest in the directories, we're happy to give you a demo to kind of show you the type of information. Knowledge is power. So great. Thank you so much.